Thank you so much, all of you, for coming here this evening. Our company, Mutations, offers genetic testing through doctors and consultants. And we're delighted to invite Dr. Anand Saggar to talk about the value and role of clinical genetics in cancer care. Thank you.
Well, I haven't said anything yet. But anyway, thank you for that. And thank you for giving me the opportunity to talk, particularly because I think clinical genetics is very much the hot topic, isn't it? It has been for years. It's expanding. And I think that the fact that we can get testing now so much more easily means that we need to really understand a lot more about the benefit and the value. And sometimes patients say to me, what difference will it make? And so tonight I'm concentrating on cancer, but I know that Mutations offers other testing as well for risk profiling in other areas and pharmacogenetics. And I think that would be another topic and another subject, another lecture in its own right. So you'll forgive me if I just focus a little bit on the role of clinical genetics in cancer care. And I think it's developed, it's changed a lot more. It isn't just anymore about saying you've got a gene and then not having anything more to say. There's a huge amount, and I hope by the end of today that you'll be able to see that I've talked to you a little bit about what I call the genetic architecture of cancer predisposition, the assessment of genetic predisposition to cancer, which we do in the old-fashioned way when we were at medical school. How many people are doctors here? Oh, marvellous. Well, I'm sure I won't insult your intelligence, but it's the old-fashioned way. One of the strongest, powerful indicators we have is to look at family history, and that's a very important element, but increasingly now we're recognizing that not everyone has necessarily the family history. They may not have the large structure that people had before to identify who's at risk. So genetic testing is becoming an increasingly potent way of identifying those at risk. There's also the issue of multifactorial cancer risk, and then also about how management has changed. So I'll try and run through some of those things in the time that we've got and leave some time for some questions. So here you see we've got this model which is showing that we clearly have some what we call rare variants, sort of high penetrance of Mendelian genetic genes that if you have a copy, you're at a high risk of developing complications from that gene, in this case breast cancer. And we'll talk about later on, I'll show you some of those examples and some of those. And clearly you can have variants which have a small effect and variants that have a huge effect. And this is really what we're interested in, is this high risk element there. And then obviously you get variants which have an intermediate effect and you're not sure about what they are. And then lots and lots of common variants which are implicated often in what we call multifactorial diseases. So you could take hypertension, you could take skin color, for instance, and you could also, obviously in this case, look at cancer predisposition. And there's many of this. Well, there's many of these common variants, and it's the combination, perhaps in some respect, with different individuals as to how many of these they might get, as to why they're at more increased risk than somebody else. But it may not be at a very high level. So again, identifying common variants too can sometimes be of help, rather than just focusing on the major Mendelian genes. And in fact, it was one of the reasons why Angelina Jolie decided and precipitated, not only did she have a very significant BRCA2 gene, but she was identified as having quite a number of other significant common variants that which it made her finally decide to go for a bigger test at that time. Plus, she's a very anxious lady. Not say too much. So if we look at this, people often think that all breast cancer is due to a gene mutation, and it's not. There is definitely a proportion of women who have breast cancer, and a tiny proportion of men, no more than 1%. Out of the, I think it's about 49,000 women in the country women who get breast cancer that have high risk genes associated, maybe 5-10%. There's another big slew of women, probably about 25%, a quarter of them, who have a family history. But when we test them, we're not able to find the major susceptibility genes, classically BRCA1 and BRCA2, that will identify why they have this family predisposition. Now, it would be a mistake to say to them, you've got 3 people in the family with breast cancer, we can't find BRCA1 and BRCA2, therefore your family is not at risk. Well, that's a mistake, because the fact that they've got 3 people in the family with breast cancer suggests they may have some more minor susceptibility genes in their family. Are you with me there? So it's all kind of common sense. So they are obviously at some increased risk, but we've traditionally not looked at those minor genes, and I think that's where I think doing some panel testing in the way that's offered by Myogenes and certainly other companies too is an important way of looking at testing people who are at risk or where there's a family history. And of course then you have this huge group here of sporadic, which are isolated, and the chances of picking up a mutation are going to be small, but of course you will, and I have done in my experience, because they don't necessarily have the family structure to identify it. They don't know what there are. And we can obviously talk about many other conditions, not just breast cancer, but the high penetrance genes make up a smaller proportion for the bigger numbers. Breast cancer, I said, 5 to 10%, similarly with colon and prostate, but then you move on to melanoma, pancreatic cancers, and thyroid, medullary thyroid particularly. We know that there's a high-risk genes associated with that, the MEN genes. And then retinoblastoma, of course, we've got the genes there specifically that are highly penetrant and account for most of the retinoblastomas that we find. So each condition needs to be looked at in its own right. And, let's talk about family history. I love this slide, because why do we think anything is genetic? We think things are genetic because they occur more frequently in the family than you'd expect from the population level, and or they occur at a particularly young age. And it's the two that you're always waiting. So I always say to patients that in your family, 2 women at 90 is not as significant as 1 woman at the age of 35, 40. Now, it might sound so obvious, but sometimes people come along very worried about this very late onset cancers in their family. But you have to weigh it up against how many there are. And you can get later onset cancers, it's true. So, of course, what we're doing there, illustrating that another way, is we're looking in the family history for bilateral cancers or multiple cancers in the same individual. Here, this woman has one at 35 and 44, which is obviously raising up your eyebrow because it's such a young age. And then you're also looking at multiple cancers in the family. I mean, you must know this. I apologize if I'm preaching to the converted. But it's the way we do it. And then, of course, you're looking also then at similar cancers that can occur in breast and ovarian running together. So that's what we're doing all the time in the family assessment. And traditionally, that was really largely what clinical geneticists did. But we've now expanded the role, and with mainstreaming, everybody's able to do gene testing in a way that wasn't previously possible. So when we're looking at breast cancer, we're back to this architecture model. And with the familial side, this is where we often don't have the genes. And we have this multifactorial type of model, where we look at the other things that may be interacting, like reactive oxygen species, maybe influencing the food we eat. You get these minor genes that may be having some slight ineffective DNA repair mechanisms. We get all the external factors that you hear about in the Daily Mail every other week. Obesity, red wine, cigarette smoking, I don't know, talking to your neighbor rudely, whatever else. But the point is what effect they're having, it's difficult to tell. And of course, you've also got the external effects and ionizing radiation. So all of these things contribute. But remember that people who have women or anybody who has breast cancer still fit within a profile which is within the general population. So just because you have the gene in this red with the breast cancer cases in this instance, it doesn't mean you'll always get the cancer with a high risk. You can have a less penetrant gene, which goes back to my earlier point. And similarly, if you don't have the BRCA1 and you're a general population, some people will get a higher chance and a higher risk of getting it. And and one way of looking at that is that 20% of women who carry a known BRCA1 mutation, will not get breast cancer in their lives. There's something protecting them. And of course, in all of this, you have to remember, we're not looking at any of the sort of supposedly protective genes. We're only looking here at susceptibility. And there must be other modifying genes. Well, first of all, we've got the other one of the other copy, because it's a dominant disorder, which means if you carry the mutation, there's a 50-50 chance of being passed down. But if one is abnormal, the other gene, the normal gene, you might say, is acting as a modifier. And then you've got all the other variants are acting as modifiers. And so trying to tease all that out can be a challenge. And if we use simple algorithms, this looks like a very complicated slide, but I just want you to look at this in a different way. If you look at the yellow, they're all the people who have a low risk, and the blue shadow is all the individuals that have a high risk. So really what you want to do is to pick out only the blue people and screen them. If you use age alone, you miss these green ones here, which are the young women under 47. So you'll screen them, and you'll screen all these people who are not at risk, but you're just doing it because they're by age. So you're wasting a lot of money. Yeah? So how can you narrow it down? Well, I think, in my opinion, you've got to look at the breast cancer genes and the polygenic risk. And I think that that's a way of teasing out and trying to narrow down the limited resources which we have to try and screen the general population in the right way. And the same can be applied for, did I move? Yeah. This one. So this one, similarly, if you get women who've actually got the breast cancer, these are the women who are at the high risk, and then you've got screening by age. You'll be screening these women for a lot longer as well. But if you can do the age and the polygenic risk, then you get the younger ones who should start earlier, and the women you can exclude who are not at risk much later. So it's a really neat way, and this is the whole tenet of what I think is that we have these genes. We can identify risk. We can identify multifactorial factors as well. And it isn't just about going off and having a test. I think it's about seeing a patient, putting it all together as a clinician, as an advisor or a counselor, and trying to identify who is the coned higher risk population and using adequate resources effectively. And of course, it's the larger proportion of family cancers that are familial that we're trying to narrow down. The ones with the high risk, they're more easy to find. And therefore doing a panel, in my opinion, is more important than just focusing on BRCA1 and BRCA2. And of course, the insurance companies don't always fully appreciate that as to the value of it. But we're getting there. They've now accepted the need to at least test for BRCA1 and BRCA2. But this familial cancer group, we don't do routine genetic testing in. And we don't look at these multiple lower risk genetic factors, and we perhaps should. And this family history, as I said, is just a proxy marker of risk. But putting it all together, and I was speaking to my colleague who's from the commissioners, are saying that in the end what we're trying to do is this speed. We're trying to do screening, prevention and early detection. And we do that through a variety of measures, which is, of course, the family history, the testing, and mammography, and in bowels, colonoscopy, and even chemo prevention for preventing further cancers. So it's a nice model, but we've got to test. So these are the four tenets of why we identify patients with a high risk. And you'll see that this, if you read horizontally, this was really our traditional way. We had a patient with cancer, we'd explain to them why they developed cancer. That didn't necessarily alter their management or make too much difference for their processing. And it informed the relatives about the cancer risk, and we could assess who should have risk-reducing surgery. And of course, that was of great benefit. We were limited there. But now we're much, much more informed as well, also about the future risks of cancer and what treatments they can have and what value even HRT might be, and some of the chemo prevention. We've seen lots of studies looking at ovarian cancer treatment and prevention, and even breast cancer prevention from risk-reducing surgery, from prophylactic surgery and having an oophorectomy. I mean, it was said in the original papers that if you were premenopausal and having an oophorectomy, when you'd had breast cancer with a mutation, it might decrease your risk of having a further breast cancer by 80%. That was pretty strong and powerful, and I've talked to a lot of my colleagues about this, and we're still using a figure of risk reduction of 50%, if you have a bilateral oophorectomy, having had, if you've got a BRCA mutation, as long as it's premenopausal. So it's a pretty powerful tool, and of course there's chemo prevention as well that you can try. But of course now what we're doing more and more is looking at how the finding of a gene can inform medical management and surgical options. And there is some evidence to suggest that women who have a BRCA mutation might benefit and get a better response from platinum-based therapies. But still to this day, it doesn't tend to alter your immediate management of the patient, and you tend not to delay. So usually the women are coming because they want to know what to do as next steps, and certainly for themselves as to what they should do for risk-reducing surgery to prevent any further cancer. So how do we look for these high-risk cancer predisposition genes? Well, obviously we've looked at, I've talked already about family history, but we can then also take the population that gets cancer, and we can look at whether they've got other syndromic features, which I'll explain to you in a minute or two. We can also now, and this is really where we're coming, the age of genetic analysis is coming to the fore, is we can now look at not only the pathology of the cancer, but also the pathology of the through tumor testing. And this is where I think the future is going now. What we call a molecular pathology report. It isn't, you know, do you remember, those who are clinicians will know, you used to get a report saying, oh, there's huge amount of cell division, this is a very aggressive tumor. But now you can get a tumor, you can profile it, and I'll show you an example, and say, well, this is going to be a particularly poor prognosis. So it's actually amazing, you know, how you can do it. But more importantly, you can now get signatures and look at mutational rates in tumors and have an idea of where they've come from or what their origin is. And this is leading to us having to have much, much more integrated working between pathology departments and genetics analysis and treatment and oncologists. So when we look at this graph, which I showed you before, effectively you're trying to place these genes, which we talk about BRCA1 and BRCA2, but PALB2 now, more and more, there's some recent papers suggesting that PALB2 has as much risk profile as BRCA2 mutations have. So we're now learning, as we found more and more of them, how it's more important to be looking at a wider profile, together with doing a lot of testing on TP53, for women which have breast cancer, particularly TP53 if it's an early onset at a young age, or triple negative. And then we're finding that some of the women can have these lesser genes and ATM genes or CHEK2, and there are some new guidelines going to come out suggesting that for people in the NHS they should have a panel which includes ATM, CHEK2, TP53, BRCA1 and PALB2. And I think that's a more sensible profile to do, because it would be a tragedy, in my opinion, to just do BRCA1 and BRCA2 and miss it and find they've got a PALB2. But I have enormous problems with the insurance companies trying to convince them that they should really do the wider panel. They're still very focused just looking at BRCA1 and BRCA2. And it doesn't cost any more, particularly in my opinion, to do them. And of course, you're looking at these common variants. Now, of course, finding those can be a challenge. You've got to get the right lab. But again, each individually, the increased risk from common variants is probably no more than about 1.1 risk ratio above the population, which is minor, but they're all additive. If you've got 2 or 3 of them, then you're becoming 2 or 3% above the population, 2 to 3 times above the population risk. So they're of value to find them, but trying to understand them and analyze them is the problem. And here there's a just rough review that you'll see here that with ATM you get 2 to 3-fold increase, BRCA1 10-fold increase, CHEK2 2-3-fold increase, and then you've got these other genes as well where you've got NF1, P10, but these are obviously different types of cancers. So we're building these profiles using breast cancer associated genes from having looked at panels, having discovered what genes different people have across a much broader range. And as I mentioned to you, BRCA mutations can change the management of cancer patients, and particularly you've heard in the press, I'm sure, about PARP1 inhibitors, which are specifically valuable for people with breast cancer mutations, BRCA1, BRCA2, because it attacks particularly the pathways that repair the tumor tissue. So if you have the BRCA mutation, then you have got one leg, you might say, of the repair mechanism automatically knocked out because of the mutation. And so if you give PARP1 inhibitors, you knock out specifically the second repair leg, and that makes the tumor very unstable, whereas other tumor treatments might not hit that other repair mechanism leg, and therefore there's still a way that the tumor can self-repair. So PARP1 inhibitors can be beneficial, but they're usually not used as first line. They're still used very much more for reoccurrence. So again, individually may not make a difference for the woman who's immediately diagnosed, but having a mutation analysis is very important for their management, their prophylactic surgery, their surgery at the time of their mastectomy if they need it, and obviously the relevance for other family members and for them specifically about treatment if it reoccurs. So if it's in the germline, of course, then it's got them a very increased lifetime risk of other cancers, which is what I talked about doing a prophylactic oophorectomy. It's also about the reoccurrence risk in the other breast. And of course, finding a mutation generally gives predictive testing results for relatives, which is of course very important. Now, there are of course in the general population, some populations which are particularly prone to having mutations, and they can be offered testing even though they don't have cancer themselves. In particularly, we talk about the Ashkenazi Jewish population, which have a high prevalence of BRCA1, which you've already seen has its own right, a high risk, and doing a very specific small number of mutations will give you a very high reassurance if they're normal, that they're not at any significantly increased risk. And so this is where population level testing is also of value and benefit. So, I'll just skip that. So I want to just talk a little bit now about pathology, triple negative cancers, and move on to talking a little bit about syndromic features which are associated in some individuals with a small risk of tumors, P10 in particular. We can see lesions on the skin, you get lumpy breasts, and there's a small increased risk of cancer that you can get, and they can sometimes get hamartomas. And I left this in because this is Pearce-Jaeger, where you get juvenile type of polyposis characterized by this pigmentation around the mouth. So again, I always think it's important that patients with BRCA mutations should be seen to make sure that it's not part of a syndromic association. And I think there is value in making sure you've seen the patient for that reason. Obviously, if there's a clear dominant family history, you're well on the way to understanding it's likely BRCA1 and BRCA2, but you can be caught out sometimes. And I think it's very important. And I've seen a couple of women present with breast cancer who've had a P10 mutation. It's a very small risk, but you don't want to miss them. I've had one woman who had very mild NF1, which is when you get brown patches on the skin, and she had breast cancer, and nobody had really recognized it. They just thought they were birthmarks. So examining patients has a value. I'm always encouraging good old-fashioned medicine. See the patient, examine them. So I want just to focus a little bit more on some of the new technology and some of the really new advances as to how we can identify tumor origin and tumor profiling, which is not widely available, and this is really kind of quite hot off the press. I don't know, have you heard about the 100,000 Genome Project? So we're trying to look at 100,000 genomes, not necessarily people, and looking simultaneously at the tumor as well as the blood and comparing what you see. So tumors or mutations which are only in the tumor, not in the blood or the germline, are called somatic, and if it's all over the body, we call that in the germline, so it will obviously be in the tumor. And you can work it backwards. Obviously, if it's in the blood, it's going to be in the tumor. If it's in the tumor, it might be an indicator that it's actually come from the germline. So testing the tumor is often very, very valuable. But what the 100,000 Genome Project's been doing is actually looking in a much, much closer way at all of the mutations that occur. Now, I shouldn't take credit for this. It's been done with work from South Thames Clinical Genetics Department, particularly the leads there, Katie Snape and Helen Hansen, as part of the 100K project team. So I must give them the credit for this, and they've kindly lent me some of their slides. But cancer is this battle of these two genomes, which is in your constitutional germline, and also the genes which are just in the tissues outside that may spontaneously mutate. And pre-100K, you see, we only did a very limited number of mutations in the tumor tissue, mostly EGFR, epidermal growth factor stuff, lung cancer, limited germline mutation for BRCA mutations, and that was really all we did. But now with 100K, as I say, we're looking all over. And what the 100K is doing is looking for very specific changes in the genes which are considered driver mutations. These encourage more mutational change to occur in the tumor. And because it's paired analysis, looking at the tumor and also the germline from the blood, it gives you a very powerful type of analysis. And when you get the result, of course, you'll find a mutation because it reports it like this, and you'll say that it's got a TP53 somatic variant and that they may be eligible for trials. And of course, you have to then account for whether it's actionable or not. But that's the clinical side. Now you've found a mutation, but you've got lots of other variants. And oh my goodness me, the variants, they cause a headache because you don't know how significant they are. You have to analyze them. There's a lot of bioinformatic information that has to be done, particularly from a genome. But that's the challenge. And as we do more and more patients, that's why we're trying to do 100,000 patients, 100,000 genomes, because it's only by building the database and knowing all the common variants and what frequently occurs will you then be able to get an idea of what is actually irrelevant and what might be a more minor gene and have greater penetrance. So testing and doing genetic testing is important. And there are some clinically actionable variants for breast cancer. Of course, BRCA2, approved variants for breast cancer, there's ERBB2 overexpression. There's germline BRCA mutations. Obviously, that's hugely actionable. And then there's other genes that control growth and development and overgrowth. So in particular, these pathways of PIK3CA and PTEN, which I showed you already and I mentioned earlier on, and another pathway along the overgrowth pathway, which is AKT1, Proteus particularly. So you have to bear in mind, as I mentioned, that there are naturally occurring mutations that happen all the way through life. And the gold round circles are what we call passenger mutations. They are just mutations that are just happening as part of the natural mutational process, and why ultimately, if we live long enough, we're all going to get cancer. Those mutations are occurring. And then you get spontaneously, sometimes, if it's not in the germline, you'll get a driver mutation, which is these stars. And then once you get the driver mutation occurring, that then creates an acceleration in the process and may change what is a benign tumor to an early invasive tumor. So you're building up this profile, and eventually then you'll get other mutations which may make you resistant to chemotherapy or various other things. So this difference between what we call the driver mutations together with the passenger mutations is very important. And we can then build up what they call these circus plots, which are visual representations of the whole genome, the whole of the cancer genome. And you get an idea of the signature occurring. So if you look here, this is really looking at what I don't want to complicate this too much, but effectively you'll get a cancer, which is homologous recombination defects, where basically the DNA is not able to repair itself properly. And you'll see recombinations occurring, which is what all these green lines are. And it's a massively number here compared to a normal individual. So this is a wonderful visual representation to say you've got a defect, a gene defect, a homologous recombination, just by looking at the signature. And that was a particularly a germline BRCA2 mutation compared to somebody who doesn't have a BRCA2 germline mutation. And that's a very powerful indicator of there's something genetic. And then, of course, the challenge will be to find that. And we will do that eventually. And 100,000 Genome Project is trying to help that process by looking at these mutational signatures and then identifying what particular type of signature they have. Now, each of our cells is subject, as I say, to this multiple mutagenic process. And process is as a result of all the different exposures and all the multifactorial elements of it. And these changes give the clue to what's underlying it. And what they're doing is fundamentally is looking at the actual change in the base, but then being rather more clever and looking to see what's either side of it, even up to 5 base pairs either side, and then that produces a signature. Now, you might say, well, how the hell do they do that? Well, it's very complicated computational stuff. But fundamentally, it's looking at what's occurring. It's looking at weighted sets of co-occurring terms. So it's a bit like saying, well, Chinese people all have their eyes in the right place, but they all have this epicanthic fold, or I don't know, somebody else has a particularly big head or something, and they have a particular size head, or other people have a different type of feature that is occurring with more frequency. And this is a huge kind of what they call non-negative matrix factorization, where you don't take anything out, you just add things in. And you don't need to worry too much about it, but essentially what it does is it looks at the tumor and it says what is occurring again and again and again in that particular tumor and not in the other tumor. And you get these mutational profiles like a heat map, which then give you a particular signature, telling you that signature A is occurring here, in the BRCA2, and then this particular signature D is occurring more frequently with a higher proportion. And doing some complicated algorithm, you can see within different tumors which ones are particularly common. And here you'll see in the breast cancer, these orange 7, signature 3 is particularly prevalent and quite common across many of them. And you can build up these sorts of tables as well, which will say that these signatures are occurring with more frequency across different types of tumors. And in breast cancer, you've got signature 3, which is in ovary, in neuroblastoma, and in breast. So you look at signature 3 and you'll say, well, signature 3 has been found to be very high in breast, ovarian, and pancreatic cancers. It's associated particularly with these double-stranded breaks, homologous recombination, and you can say that that is very strongly associated with BRCA1 and BRCA2 mutations. So this becomes another way of profiling your patients by doing the tumor analysis and saying, this person definitely needs to be tested for a range of genes, not just BRCA1 or BRCA2, but probably some other genes that they might find from these signatures. So cancer genetics is changing. Cancer genetics is becoming really complicated. Cancer genetics has got to have gene testing as part of the armamentarium of assessment of patients. And all the testing we do goes into that and builds into that. So whole genome sequencing, which is what the 100K, it can identify cancers, look at driver mutations to direct targeted therapies. It can look at mutational signatures to look at the mutagenic process and identify who's got particular homologous recombination, like the breast cancer, which might then dictate specific forms of treatment, as we talked about part 1 inhibitors, or platinum particularly. And I'm not an oncologist, so I don't have the expertise to know the specific ways in which they're treated. And then germline mutations, which of course you're still identifying, which have a relevance to the wider family, particularly when they're paired with the tumor. And as I said, management of a patient with cancer is complex enough with the clinical, the pathological, and now you've got somatic genomic data, germline genomic data, and of course the family history. And that all then feeds down. But I think the bottom line in all of this is that we've got to have much more concerted working, looking at the somatic, looking at the tumor, the germline data, family history, having an MDT and producing what I call, or what my colleagues call, an integrated molecular report, looking at all of those features to put together. And obviously, clinical genetics plays a very important part in trying to not only interpret the information, but also looking at management of future cancer risks and relatives. But I hope you'll be convinced that this new way of looking at tumors and mutations helps to provide tumor-specific clinical management algorithms or decision-making help for patients. But in the end, if there's one thing I've learned in genetics is that every day is a school day. And what you thought was unlikely to be present can be present. And I recommend that every woman in this country really should be tested for the BRCA2 and BRCA1 mutations at the very least. But from what I've shown you today, I hope you'll be convinced that if we're going to really get to the answer, to look at the lesser genes, the less penetrant ones, we've got to do a wider panel, and that's the way forward. And it's only when you find them, it's so sad when you see a woman come who says she's had breast cancer in the family, but my mother died 3 weeks ago, can I have a test? And the NHS certainly won't offer it to them. And it's hard because if you see them in the clinic and you don't find the mutation, well, that doesn't reassure you necessarily because it just means they haven't got BRCA1 or BRCA2, but they could have some of these lesser penetrant genes. The person to test would have been the affected individual. So I think that really every woman who gets breast cancer should get tested for those genes, and everyone who has a cancer really should get somatic testing, looking at mutational signatures to give you an indication or an idea as to whether or not they've got a mutation. So I'm going to stop at that point, just leaving you that you can be multifactorial, can be high risk. We've got to look at all these factors together in order to do speed, early screening, prevention and detection for these individuals. I've got some little things here which I'm more than happy to leave and hand out on your table, or I'll leave at the front there, which are just some of our breast testing protocols that we use at St George's. There's a nice little algorithm that we use to try and identify who's most at risk. It's very much NHS based because it's trying in the end to ration the number of women who get tested. It's based on the NICE guidelines, and that's for breast cancer testing, and this is for colon cancer screening. And again, I just thank my colleagues who've helped me with some of this mutational signature work. So I'll stop at that point, and you can ask me some questions. I didn't overrun. You can hand these
Hello.
Yeah.
Hi, Anand. Thanks for that great presentation. I just wanted to ask quickly in regards to the last slide that you had. Is there any actual...
This one?
I think the one before that. Yeah, that one.
Yeah, that one, yeah.
Are there any models that you use that will guide us towards whether a patient should be genetically tested or not, like the IBIS model, for instance? Is this basically the UK version of that?
This is a working, pragmatic approach based on the NICE guidelines as to who should be tested in the NHS. So yeah, this is the model that we use. It's based on the Manchester score. I mean, these protocols keep changing in many different individuals, but this is our model that we use. Yeah, and I don't think it's perfect, and that's why patients come privately, because they just fall out of this. And they can look at their family and they can see that they just don't quite make a combined age of, both cancers being, they're 49, when they got the cancer, not 50, and they can't get tested. I mean, I empathize. But the guidelines are the guidelines, and some people apply them very rigidly. So this is why we use in the NHS. And we don't have the flexibility. I'm afraid the gatekeeping is becoming more and more rigid. And of course, the testing involves checking using national cancer registries. I've got them there. You can look at them just to find it easier just to have a look at them in more detail. This is just based upon family history, though, and the age at which you get it. This isn't based on mutational signatures, which is, I think, why this is almost becoming redundant. But when the 100K comes out, there's going to have to be a section in there that says, well, what did you find on the somatic tissue? But I'm hoping that by then, they'll test every woman.
Do you think that big data would make a big difference to this? So, big data and AI seem to be what you're indicating is the solution to this. Basically, what appears to me to be the problem is the lack of data and the lack of consistent feedback of information to the systems that you're using. So do you see big data as being a solution to this, somehow feeding all that sort of testing data into one single AI system that can really run the analysis much faster than a human could?
Absolutely, but that's exactly what I was trying to show by this,
Yeah.
which is the AI. But remember this model which I showed you on the slide before, that's a very crude model. It's just based on family history and age.
But we could refine that quite considerably using additional data if we could get
Well,
it.
I think the additional data is the mutation testing,
Yeah,
the
yeah, I can see
variants, the profiling that we do, the mutational signatures, and that's what's in this slide here that you see. It is big data, and that's what the 100K is about,
Yeah.
big data. That's what that compiling all the signatures is about, and it's the power of the bioinformatics that happens. But it's like everything Victor Karku said at UCLA. It isn't just one thing that's going to make the difference. You've got to get the atom, to get your microchip being fantastically, to understand your physics. You've got to get the microchip, so you've got the computing power to work out this big data. And they've got to get the gene, because we understand then what the gene does. And all three have to move together in order to make these leaps. But you're right, big data is without doubt the answer.
Yeah, so I can see that being the key, but then there are political implications around getting that data, I guess.
Well, it's more important you've got to have the funding. If you can't have the data, you haven't got any analysis.
Yeah, it's a cart before the horse, isn't it? Yeah.
But they'll get there. I mean, it's becoming, that's what the 100K is about, and it's closed now in September. It closes, I think, in a week. And cancer was a big element of it, a big subset. And this is the kind of data that's coming out, which is, I think, would you agree, it's pretty powerful. I mean, how many times, I remember when I was a junior doctor, we'd say, the woman's, or man, they've got a cancer, and it's carcinomatosis, it's disseminated cancer, and we've no idea where it's from. Well, if we had mutational signatures, we might get a better idea. I'm not saying we always would, but it's a start. But without the data, without breast cancer testing or bowel cancer testing or whatever you want to talk about, you won't get the data. You won't get the information. Sorry, you had a question?
I was going to ask, would you advocate the role of this only in patients that have family history or a physical history, or would you advocate the role of this testing?
Sorry, you want to start again with the microphone?
So,
Hello.
hello again.
My question was the genetic testing that you're talking about. Would you advocate the use of it in only patients that have a significant family history, or is there a role for this in healthy individuals who come for health assessments and just general screening?
I think that everybody who's had a cancer should get tested, be it breast, bowel, or whatever. That's my personal feeling. But you are going to get a lot of negatives because, as I showed you right at the beginning, the percentage of major genes is a tiny proportion of all the cancers that occur. So we tried to cone down that by doing the family history assessment. So it's just a rationing process. But now, but in the private sector, I see many, many women who come because they've got breast cancer, and I say to them, you really don't have very much of a family history to make me concerned you've got a major susceptibility gene. So I say to them, it's not much point you just looking only at BRCA1 and BRCA2. I think you should look at a wider panel and look for the lesser penetrant genes, because they're more likely what's in your family or in you. But as you saw from the pie charts, the sporadic ones, they don't have these major genes. So I think somatic testing definitely needs to be done in some way, and these mutational signatures are probably the way forward because it's combining the data. And I think that if you're a general population level without any family history and no personal cancer, I think you're on a little bit more of a sticky wicket, because what are you going to test? You've got no somatic tissue to test. You could do BRCA1 and BRCA2, but the likelihood is you won't find it, because you've got no evidence base to suggest there's a major susceptibility gene. So you're going to end up testing for the lesser ones, and we don't really know enough. So the reassurance of negativity is a false reassurance in a way. Does that make sense? So I think whilst it's reassuring in its own right, I mean, it's different for Ashkenazi Jewish mutations, for instance, because you test 4 mutations and you've got 80% reassurance, roughly, that they don't have any major susceptibility gene. So I think that's fine when you've got a specific thing with a high degree of prevalence in that population. And that is a group where we will test an unaffected individual just because they are Ashkenazi Jewish. A male with breast cancer, so unusual. I think that's a good group to test. But just the average person walking in the street with no cancer and no family history, I think it's false reassurance at the moment. Anybody disagree with that? God, I can see my colleague in genetics. What do you think? You agree? Pragmatic approach. And you don't want to, we get lots of worried well, but you don't want to make them more worried and well. And I think you've got to have value to the test and the result you give them. And there's probably other things they could do to reduce their cancer risk. Like not smoking. Any other questions? Come on, I kind of stunned you all into silence. I hope I showed you something that you didn't know about. I mean, I could have talked just about nice guidelines, but that would have been very boring. And I assume you all know that these guidelines exist and that there's certain people to screen and there are protocols to follow. But in the private sector, which is, of course, what I deal with a lot, you can have testing as long as it's sensible for many genes. And I think testing's got great value. We're going forward. And it's the availability of the test at a price that you can afford is what makes it drivable, is what makes it possible.
So,
thank you very much.
Anand, thank you so much. I'm sure everybody here feels that they've hopefully learned something. It's been very informative, and I want to thank you very much on behalf of Myogenes.
Thank you.
I'd also like to add that I like what you said, that to bring affordability, and that's what we as a company, Myogenes, are trying to do. As you know, we've been all over the world to get the best laboratories at the very best prices, and as we've spoken to 2 or 3 hospitals, and we are now involved with 2 or 3 hospitals, they've found that they've managed to offer particularly the breast cancer and hereditary gene cancer tests at a much lower price than they could do, which is reassuring. It means that we can offer it, or the doctors, the hospitals can offer it to patients at a more affordable price. And as the commercial director, if anyone wants some tests, they're here. Please take them away. You don't have to pay for them until you've used them. But and anything else, our clinical director is here as well, Dr. Sir Harvey. You can have a chat with him. And again, thank you so much for giving your time and crossing over private, NHS private. It's marvellous of you, and we do appreciate it. And now I think, have a drink, have a snack, and I shall carry on drinking, which I'm sure it's probably pretty bad for cancer mutations. But thank you so much.
Half a glass a day is said to be fine.
Oh, is it? Okay, thank you so much. Thank you. Thank you very much indeed.